Hello. On to lunch, which is entitled Boom and Reform, the Big Idea Session. Joe Palco was teasing us at breakfast. They had the global health table was next to ours. They were doing their planning. And he told us not to take it personally if no one showed up for his session. Because as John Zogby just told us, people are now interested in global issues and global health. So he said, don't take it too personally if you have no one, because his session was very, very interesting. So thank you all for coming and participating. We won't take it personally that a lot of you are here, but we look forward to having a conversation today. The format is a little different than a normal panel. What we're going to hear from is a succession of speakers, 6 different speakers, who each have big ideas about how to transform the medical system here in the U.S. My name is Peter Long, and I'm from the Kaiser Family Foundation, and I'll be the introducer for the session. And I just wanted to set one piece of context for everyone. We've had a lot of discussion over the last 3 months about healthcare reform. Every 19.7 years, it seems like we have a healthcare reform discussion in the United States. And I want to propose that I think health reform in the United States is a very important idea, but it probably may not qualify by our criteria as a big idea in terms of being transformative and really changing the healthcare of Americans in medical care. I know that's a controversial premise, but I want to start with that one as it sets the context for the ideas that you're going to hear. 3 pieces of data I would give you why health reform is critically important and forms a foundation for everything that we're going to hear about this afternoon, but probably in and of itself doesn't constitute a big idea. First, a lot of the ideas we're talking about are not new in Washington. The Congress is talking about Senator Daschle, and I think Representative Tozen can attest to that we've been talking about some of these same ideas for 50 years, but certainly for the last 20 years. And personally, in 1993-94, I had the inauspicious task of reading every page of legislation that was produced in Congress and producing side-by-sides of every major piece of legislation, from the Health Security Act through the bipartisan compromise, Senator Cooper's bill, John Chafee's bill. So I literally read every single piece of legislation. And I can tell you that from the broad perspective, many of the ideas that we're debating in Congress today and debating as a nation are very similar. Clearly, we've come a long way, and there are nuances. So healthcare reform is certainly not a new topic for us as Americans. It's an important topic, but certainly not a new topic. And second, I think if anyone's been watching the Aspen stewardship work and following the progress of that group, I think they would say that they have real questions about the healthcare reform proposal specifically in Congress. Are they going to lead to improved health for all Americans? I think that's a very open question, and if I read the blue report that we had in our packets and you compare that to the legislative proposals, I think it's a very open question of whether health reform in and of itself will improve the health of Americans. And third, I would say even our president, I can quote President Obama when he said in the campaign and has reiterated many times during the health reform debate, if you like what you have, you get to keep it. Well, that's not a recipe for transformation. If you're telling Americans that if they like what they have today, then they're going to get to keep it, that's not exactly a recipe to change the entire system and fundamentally transform healthcare. That isn't to say, before anyone texts the White House or texts Congress and tells them that the Henry J. Kaiser Family Foundation is negative on health reform, that is not to say in any way, shape, or form that health reform is not a critical foundation for all of the big ideas that we're going to hear about this afternoon, and for larger things, long-term changes in how we deliver health care. It's just to say, in and of itself, I wouldn't consider health reform legislation to be a big idea. So what we're going to do is we're going to have 6 people come up and give you different perspectives and different ideas. We're going to start at the macro perspective, I think, with an idea or a couple of ideas that are very tied to health care reform proposals that are working their way through Congress right now. And then we're going to move through to the actual patient experience. We're going to get real as we move down the panel. So we'll take it from the very macro perspective around federal policy issues and some research tools, and take it all the way down to some big ideas about transforming the interactions between patients and doctors and how individuals and families interact with the healthcare system. So with that, I have the pleasure of introducing Senator Tom Daschle, who is currently a senior policy advisor with Alston and Bird and a distinguished fellow at the Center for American Progress. We probably all know Senator Daschle more as the former Senate Majority Leader from South Dakota, twice Senate Majority Leader and twice Senate Minority Leader. He's going to speak to us about his big idea is the creation of a federal health board, which is, I think, if you think about what happens, it's Senator Daschle's idea, what happens after we pass health reform, how do we actually change the dialogue in the country and move forward. It's about how do we begin to implement health reform after it happens. So with that, welcome Senator Daschle.
Well, thank you very much, Peter, for that generous introduction. Still eating, would you quit, please? No? No, by all means, keep eating, and we'll talk over the plates and silver. But I guess I'd challenge Peter's assertion that this isn't a big idea. We wouldn't be here today were it not for the fact that because it's been such a big idea for the last 70 years, we've failed to accomplish it. I can't think of a bigger idea than to transform the system that we have today, affecting the lives of every single American. And when the president says, if you like what you've got, you can keep it, his assertion isn't that because what you've got is so good, you won't even consider changing. I think what he's saying is that if you like what you've got, you can keep it, but we think we can produce something better that you're going to want to change too. And that really is the whole idea. Can we find a system that recognizes three fundamental problems in our country today? A cost problem that is literally out of control. When I was born, 61 years ago, Billy says, whoa. 61 years ago, health was 4% of the gross domestic product. When my children were born, it was 8% of gross domestic product. When my grandchildren were born, it was 16%. And if I have the good fortune to have great-grandchildren, it's now projected to be 32% of gross domestic product. How much longer can we sustain that growth path? How can we recognize that $8,000 per capita in taxes, premiums, and out-of-pocket expenses is too much? And the CEO, the Council of Economic Advisors, says that if we do nothing by 2025, the per capita cost in this country will be $25,000. That's a problem. And to solve it is a big idea. But we also have a quality problem that I think is now largely recognized, but still not one that is discussed to my satisfaction. You know, when the World Health Organization ranks us, after we now recognize that we pay more than any other country in the world, when we're recognized as being 37th in overall outcomes, whether you agree with the criteria or not, that's a problem. When we're 31st in life expectancy and 29th in infant mortality and 24th in women's health, that's a big problem. And so we've got to recognize that cost and quality and then obviously access completes the landscape as we look at how big this problem really is. When you've got 50 million people who don't have access to insurance and 18,000 people die every year as a result of their lack of insurance, that's a problem. When 48% of those who have insurance still can't get the care they need, that's a problem. When the life expectancy on Pine Ridge Indian Reservation for an Indian male is 47 years, approximately what it is in Botswana, that's a problem. So it seems to me we've got some fundamental problems that have been so monumental, so large, so complex, that we haven't been able to solve them. And we haven't solved them for a lot of reasons. One is that I don't think we've really looked at what our goal should be as we analyze the components of this problem. I tend to think of healthcare as a pyramid in any society, where at the base of the pyramid we have good primary care and we work our way up that pyramid until you get to the most sophisticated care at the top, an MRI or a heart transplant. Every society starts at the base of the pyramid and they work their way up until the money runs out. In the United States, we start at the top of the pyramid and we work our way down until the money runs out. And not that many people get good primary care as a result. So the question is, can we invert the pyramid and change the paradigm from illness to wellness? And that, too, is an issue that is not only complex, but it is extremely politically divisive. And so the question comes, well, how do we do this? Well, we're only going to do it first if we see extraordinary presidential leadership, and we see a president and a Congress willing to commit the resources and the political capital to create this new opportunity to address all three problems simultaneously. We've tried to do it incrementally for the last 15 years, and it's almost impossible to attack those complex and extraordinarily far-reaching problems and do it piecemeal, a step at a time. It just can't be done. So creating this new infrastructure is something that is so critical. Changing the paradigm and reversing the pyramid is going to take a fundamental, big idea with regard to public policy. The exchanges allow us to create the mechanism within each state to begin to put the process together in this new architecture to allow everyone access and ultimately to allow everyone the opportunity to get good quality care at a reasonable cost with a modified community rating. And then, of course, we're not going to solve this problem unless we get into meaningful payment reform. Payment reform is going to require that we get away from volume and move towards value. Recognizing the importance of comparative research and evidence-based medicine, there is absolutely a strong, strong imperative to create this new payment infrastructure as we create the system itself. Well, I have felt from the very beginning that the best Congress could do, having been there along with Billy and Dan Glickman, who's back there, and maybe others who I don't see in the room just now, but many of us have looked at this for a long period of time and have recognized that one of the toughest things for Congress to do on a regular basis is to manage our healthcare system, recognizing this complexity and the extraordinary political pressure that comes with almost every decision. We go from the war in Iraq to climate change to the reimbursement of oxygen rates. And I must say, as we get into physician reimbursement, oxygen reimbursement, home health care, and the myriad of other challenges, every constituency, every single issue involving public policy and the management of a $2.5 trillion sector in our economy becomes almost impossible. And so every year, with the best intentions, Congress attempts to address these things in a piecemeal way, and every year the problems get worse. The costs go up, the access goes down, and the quality declines. And so I've come to the conclusion that we need to find a new management infrastructure. And my notion for doing this is simply to take lessons we've already learned. Back in the early 1900s, we had similar problems with regard to our monetary system. Congress up until then was really delegated with the responsibility of creating a monetary system and making it work. And we were facing many of the same problems we are in health back then with our monetary system, and of course still do today. But we created the Federal Reserve System as an independent entity to evaluate and to manage our monetary system in a way that has now evolved over 100 years. I believe we need to do something similar in our healthcare system. An independent approach that takes the politics out of the system, that recognizes the need for an autonomous, politically insulated, high degree of competence associated series of decisions that can only be created by the creation of this new entity. Now, there are three versions that are out there that are now being considered. The first is the health. It's called the Health Integration Authority that the Blue Ridge Group and others have suggested. That would really take the entire infrastructure within the whole healthcare system and create this management authority to decide things like how we're going to reimburse, how are we going to create this new payment infrastructure, and how are we going to design ways with which to bring down costs and improve quality. But it would be system-wide, not just for the federal government. Then we have IMAC, the Integrated Medicare Advisory Commission that the President, Peter Orszag, have suggested, which really is designed only to deal with Medicare. And Medicare would be the vehicle through which all of these decisions would be made. Once a year, IMAC would make these decisions, make recommendations to the President. The President would have 30 days to accept them. The President, if he accepts them, would submit it to Congress, and they too would have 30 days, and we would move forward on an annual basis. Then you have the Rockefeller-Cooper MedPAC, or Super MedPAC approach, that really does much the same thing as the IMAC approach. It simply takes out the step where it's submitted first to the President. They make recommendations. The Congress has the right to overrule or directly confront the issues, and much like the BRAC system for base closing would have an opportunity to vote up or down. One of those three systems would work. But I must say, we can get the policy right. We can get the design right for what it is we want to do in creating a high-performance, high-value system based on lower cost, greater access, and better quality. But if we don't get the infrastructure right for management, none of this will matter. Infrastructure is critical. And an IMAC or a MedPAC or an HIA is perhaps the only best hope we've got to make it happen. Thank you all very much.
Thank you. Thank you very much. I forgot to say in my introduction, there's probably no one in America who understands health policy, politics, and the way things work in Washington better than Senator Daschle. So thank you very much for that. It was a great introduction, and I think a great overview of the framework for healthcare reform, but also a very innovative idea that could be transformative in the politics of healthcare and the economics and politics of healthcare. What we want to turn to next is Betsy Nabel, Dr. Betsy Nabel, the director of the National Heart, Lung, and Blood Institute, and also a member of the Federal Coordinating Council on Comparative Effectiveness, will talk to us about a big idea, and I think it's an idea that's been talked about a lot, and is probably one of the central issues in terms of achieving what Senator Daschle had talked about in terms of a high-performing healthcare system that really produces value, and that's comparative effectiveness. So Dr. Nabel will come up and speak to us now about, I think, one of the most important tools that's being discussed in terms of the healthcare reform debate, the comparative effectiveness research. Thank you.
Well, thank you very much. To follow you, Senator Daschle. What I'd like to do is discuss the topic of comparative effectiveness research. I'm come to this topic as an institute director at the NIH and representing the NIH and the Federal Coordinating Committee for Comparative Effectiveness Research. But I also come to this, like you, as a member of our healthcare system and a consumer of healthcare in this country. So my big idea, the hypothesis that I want to put on the table, is that comparative effectiveness research can be an effective tool to achieve two goals. The first being to improve medical practice and patient care, and that's by getting the right treatment to the right patient at the right time in the right setting, a phrase you've probably heard over the past few months. The second goal is to bend the curve, to bend the Orzog curve, to achieve healthcare savings by focusing on quality and value rather than on volume. So let's step back a little bit. What is comparative effectiveness research? And I'm going to simply cite the definition that we came to in the Federal Coordinating Committee, because that will be the definition which will drive the monies that currently are within the Department of Health and Human Services. So comparative effectiveness research is the conduct and synthesis of research comparing the benefit and harms of different interventions and strategies to prevent, diagnose, treat, and monitor health conditions in real-world settings. The purpose of this research is to improve health outcomes by developing and disseminating evidence-based information to patients, clinicians, and other decision makers, responding to their expressed needs about what interventions are most effective for which patients under specific circumstances. And there are three factors that come into terms here. One, we recognize that comparative effectiveness research must address diverse populations. Second, the defined interventions might be medicines, procedures, technologies, diagnostic testing, behavioral change, and delivery system strategies themselves. And finally, this research necessitates the development, use of a variety of data sources and methodologies. So let's stem back a minute and talk about what may appear to be the short history of comparative effectiveness research. This term really gained popularity with the ARA, American Recovery and Reinvestment Act legislation, because in that legislation there was $1.1 billion that was devoted towards comparative effectiveness research, and that money went to the Department of Health and Human Services. $400 million to the NIH, $300 million to AHRQ, the Agency for Health Research and Quality, and $400 million to the Office of the Secretary. That legislation mandated that each of these agencies needed to coordinate and integrate their spend plans, and that in addition, the Office of the Secretary charged the Institute of Medicine to come up with a report over a short term to guide the spending of the Office of the Secretary money. So that really provided a jump start to the conversation. And indeed, at the federal level, since the spring, over the past 4 to 6 months, there's been an extraordinary effort at coordinating and integrating activities. AHRQ has been focusing on identifying research gaps and engaging in evidence synthesis. The NIH has been very much involved in generating the research evidence. And the Office of the Secretary is still in play with their plan due to Congress at the end of the month, but will likely focus on areas that will complement what AHRQ and the NIH are doing, that being data infrastructure, dissemination, and translation. Now, I should add that comparative effectiveness research is really not anything new to DHHS. In fact, the NIH has really been engaging in CER for decades. We simply haven't called it that, but clearly we've engaged in clinical research for years. And indeed, many of the institutes have supported studies which have generated important knowledge. For example, in my institute, Heart, Lung, and Blood, several years ago, we conducted a study called ALLHAT, which compared various approaches to treating hypertension in the community. And indeed, we found that use of a generic diuretic was just as effective as the more expensive forms of antihypertensive treatment. The problem is that information has really never been effectively implemented into medical practice. The other piece that came along the way then is over the course of the summer, the IOM did generate a report which consisted of a number of recommendations, along with a list of the top 100 priority areas that comparative effectiveness research should focus on. Now, it's really quite interesting because of those 100 top priority areas, the NIH is already funding research in 97 of those areas. So it really bespeaks the point that there really is a tremendous amount of activity going on at the NIH. But I think also importantly then, over the spring and the summer, there have been several themes that have emerged as the healthcare debate has intensified. One of the themes is that comparative effectiveness research is an important component of the healthcare reform discussion. It's not going to go away. There's a very keen interest by the President, as you heard in his Wednesday press conference, that, quote, we want to know what works, end quote. And that's the language for comparative effectiveness research must be conducted so we know what diagnostic treatments, what therapies really do work. We also know that there's a very keen interest by Peter Orzog in the OMB, since Peter has a responsibility for controlling healthcare spending in this country through OMB. The second theme that has emerged is that CER will be part of the healthcare agenda for many years, certainly post-ERA. And we don't know at the present time what form that will take, but certainly CER is going to have to be married to one of the three modalities that you suggested, Senator Daschle, whether it be a health board, IMAC, or a super MedPAC. CER is going to have to be part of that. The question will be is who will be making the decisions about what will be the research priorities, how will that funding occur, and what are we going to do with the information. So I think this leads us then to what turns out, I think, to be the absolutely critical question, is how will the information and the knowledge generated by CER be used? And again, the fact that the NIH has been generating so much of this information for years, but it simply hasn't been implemented. As a physician, I'm very hopeful that this information can be used to improve medical practice and improve patient care. As a cardiologist, I say that much of what we know about cardiovascular medicine is the rule of halves. Half of what we know is actually implemented by practicing physicians, and of the half that's implemented, only half of patients are adequately treated. So if we simply took what we already know about what works in cardiovascular medicine, particularly on prevention and wellness, and fully implemented, we could achieve great strides. Second is the cost of care. Will evidence-based medicine be used to influence reimbursement decisions, and how are we going to go about doing that? And again, I think that's a topic that we're going to continue to discuss. We're hearing a resistance. Clearly, if there's a perception that choice will be constrained or that access and payment of experimental therapies are constrained, there's going to be a fair amount of resistance. So how do we preserve choice and innovation in a setting where we absolutely do need to constrain costs? So as we go forward, I think that there are going to be 6 important elements of the CER discussion at the national level. First, we have to focus on evidence gaps. What do we know and what don't we know about what works? Second, we have to have stakeholder input. In other words, payers, providers, patients, the federal government, pharma, all have to be part of the conversation. Third, we need to generate the evidence, and again, that's the NIH's stronghold for many years. Fourth, we're going to need a data infrastructure. That's going to entail new methodologies. We're going to need distributed databases. For example, expanding the coverage data within the Medicare databases, adding Medicaid data, expanding access by the community researchers. We're going to need integrated IT platforms and common standards. Fifth, we're going to need methodologies and pathways for dissemination and translation. We're going to need economic incentives to reward quality and value rather than volume. Patients are going to need to be their own advocates and assume personal responsibility. They're going to need access to their own electronic health records and broader health information. And last, physician organizations are going to have to be actively involved in developing guidelines and implementation. And then finally, we are going to need CER integrated in some type of a health board or a super med pack or an IMAC to really influence reimbursement decisions. So in summary, I think comparative effectiveness research can be an effective tool to generate evidence to demonstrate what works, to improve our knowledge so that knowledge can be used to inform medical decision making, and then finally, hopefully, this will ultimately be used to bend the curve. Whether this will occur or not, I think is the open question that is before all of us today, and much of that will depend upon political will. Thank you.
Thank you very much. Let me amend my first statement after listening to our good big ideas here, that healthcare reform has the potential to be a big idea if we listen to what Senator Daschle and Dr. Nabel, if we take their advice to heart. I think those are, in all seriousness, I actually think those are 2 of the central issues if you're watching either in Washington from up close or from afar in the rest of the country. Getting these 2 issues right really will make a difference, and really will make a difference between whether we do a lot of good things for the uninsured Americans, which are vital, our economy and other things, and whether we truly are transformative of our medical care system. So there we go, a statement amended. We're making progress. So let's switch gears a little bit, and now we're going to have the Honorable Billy Tozin come up and talk to us about a separate train running down the track, and we've heard a lot about it. I think I'm very interested to hear his perspective on personalized medicine. As all of you probably know, the Honorable Billy Chosen is the CEO and president of Pharma since 2005, and before that, he served as the representative of the 3rd District for Louisiana for 13 terms and as the chair of the Energy and Commerce Committee. So he's going to talk to us about personalized medicine. What do we know about it? What are the big ideas? And what does that mean in terms of the transformation of the medical system? So welcome.
So unlike Senator Tom Daschle, who grew up in the pristine politics of the Dakotas, I come from Louisiana, where we once had a governor, Earl Long. You probably saw the great movie Blaze, which starred Paul Newman as Earl Long. Earl was an amazing character. They missed the most famous, I think, Earl line expression in that movie. Earl Long once said, "When I die, if I die." He said, "I want to be buried in South Louisiana so I can stay active in politics." So if you weren't born in Louisiana or Chicago, you might not understand that. We can't escape death, we know that. And we may or may not be able to vote after we die, unless you live in those two jurisdictions. But we can do something about the way we die. And the way we die ought to be that the day we die, we ought to be the healthiest individuals on earth. That ought to be the healthiest day of our life, if we can get there. So what Ms. Nagel did was raise an essential question about that, and I will address a truly transformational idea, and one that is truly a big idea, kind of kicking around right now, kicking around politically, but most importantly, kicking around in labs all over this country and all over the world. Can innovation save our lives to the point of leading us to that date when we die so healthy? And can it also save us dollars? Or will innovation cost us so much that the CER Commission will be saying, "Sorry, you can't use that great new medicine, it just costs too much. Sorry, we can't put that in the government formulary." Cancer. And 5 years ago, they gave me a 1% chance to be alive. I can talk to you a little bit about personalized impressions about healthcare and medicine. I'm very lucky to be with you. The question is, can we dramatically change the way in which medicine works in our healthcare system so that innovation both saves lives and saves dollars? Or will it inevitably push us to the choices that Europeans face? You see, the medicine that saved my life has been denied to the people in the UK. The drug was Avastin. It was tried experimentally on me. In the UK, they took it up and said, "No, it's not cost effective." And that's what people fear about CER. Is it going to lead to that? Or is there a better outcome for us that is truly transformational? Well, let me take you back to that central issue of the practice of medicine. Think of that term, the practice of medicine. What is the practice of medicine today? The practice of medicine today is that when you have a problem, you go and get it diagnosed, and then the doctor tries to find the right therapy, the right medicines, the right surgeries, whatever may be necessary to help you. In the case of our products, medicines, it's often a shot in the dark. It's often a hit and miss, trial and error. It's one of the reasons why you hear so much about Me Too drugs. Maybe 4 or 5 drugs in the same disease category. The doctor has to find out which one of those 4 or 5 works for you. The right medicine for the right patient at the right time in the right circumstance. And he does so with the best information he has, the best information we can give him because we haven't had a good comparative effectiveness analysis of what medicine is going to work for best for him and what's affordable. All that comes into the question. Doctor doesn't also know whether you can tolerate that medicine. I can tolerate a medicine, perhaps you can't. I learned that in cancer therapy. They gave me all the lists of things that were going to happen to me as side effects, and I almost walked away. I said, I'm not going to go through that. I'd rather die. And the doctor said, no, Billy, the law requires me to tell you that could happen, but it's not all going to happen to you. Well, my hair didn't fall out. I grew hair. The guys next to me were losing hair. So it's weird. We're all different. You mentioned something, Stagel, in your presentation, that CER had to respect the differences in diverse populations. Well, here's the good news. Here's the great transformative idea. We're about to enter a world in medicine where medicine not only respects the diversity of groups of populations, it will respect the diversity of individuals. We're going to move to personalized medicine. And whether we like it or not, the science is advancing faster than our policy is. It's rapidly advancing. And when we move to personalized medicine, the beautiful payoff is the doctor will not have to shoot in the dark. He won't have to guess about which medicines are going to work for you. He will know more precisely that this medicine, in your genomic condition, with understanding of the biologic pathways of that disease, will work for you, that you can tolerate it, you'll have a good effect, and by the way, we've designed it so it's much more user-friendly. You're more likely to take it all the way through your course of treatment. The last question is, can it be more affordable? Cost against innovation. Ezekiel Emanuel, in his book, asked that question. He said, we can really save our healthcare system tons of money. All we got to do is shut down innovation. Just take old medicines. Quit trying to find the new ones, because they're expensive. The new biologics are going to cost $1.5 billion to develop over 10, 15 years. Does it have to be that way? Does it have to be? Can we save money somehow in that process and produce these incredible, personalized medicines in a much more productive, efficient fashion? Let me give you an insight as to why this new drive towards personalized medicine is not only going to save lives dramatically, but it's also going to save us money. Think about this with me. We make medicines today. We don't know why 30% of the population reacts favorably to them. So we got to give it to all 100%. Somebody's dying of sepsis. It's where your body goes to war against itself. Your immune system literally turns on your body and kills you. And when sepsis hits you, you better have some medicine quick. And we make a great product. We give it to everybody with sepsis, and we know 30% of the time it's going to work. We also know 70% of the time it won't. And we don't know why. But we're going to soon know why. Because as we study the incredible new biologics that are coming out of great new studies from the NIH or from our individual companies and academia all over the country, we're going to know precisely how that disease pathway works. We're going to know precisely how the combination of genes fosters that pathway. And we'll also know the effect of one gene on another. We're learning, for example, one gene doesn't cause it. It's a combination. And very often there's a gene in there blocking the others. We're going to get to that point where we understand why this medicine does the job of stopping the progress of this awful disease, and this one doesn't. We'll also know what patient to give it to. Well, I learned at a New York session with scientists from all over the country. We were awarding a great honor to one of the scientists at Dana-Farber, who's done mouse studies using human tissues in the mice and then testing the medicines, that 9 out of 10 men probably don't have to make the difficult choices they have to make with prostate cancer. That 1 out of 10 had better have surgery or radiation or chemotherapy. But you know what we do today? We give it to all 10 because we don't know the one. We sit down with these guys who get prostate cancer, and we all will, guys, if you live long enough. 100% chance. We sit down with them and say, you got a horrible choice of radiation or surgery or chemotherapy. When the truth is, if we understood exactly how those genes work and how it is that some men have a blocker to the progress of the disease, you might have cancer of the prostate and it never spreads because your body is designed with a particular gene blocker that prevents it from spreading. If we knew who you were, we could individually treat you, saving the costs, the suffering, the awful decisions that all the other men have to make. If we knew who responded to the medicine in sepsis, we could design a medicine for the other 70% by modifying it so that it worked for them too. That's where we're heading. We're heading to the place where doctors won't have to shoot in the dark. Won't be hit or miss. They'll know in advance that this medicine will work for you and will not work for you, that you can tolerate it and you can't. And we'll know in advance and therefore more precisely provide medicine for those who need it the most. That's a great day, and it's coming. And we ought to ask ourselves, is that worth investing in? Now, we love innovation in America. I bought the first $1,500 Betamax. I think I still got it. Bad decision. Bad decision. We love innovation. We buy all those innovations. We understand innovation, gives us all kinds of new products. We love them and we enjoy them, but we're scared of innovation and the cost of innovation when it comes to medical innovation. The fact is, we're heading to a day and a time when we understand your genomics so precisely that we can do a total screen for well under $1,000. We're getting close to that. I'm part of a project with the X Prize Foundation that's going to develop that kind of technology. And when we get to the point where we can screen you thoroughly, not only screen you, but know what it means, know what it implies in the terms of when disease is likely to strike you, when in the process of your life are you likely to have a series of gene-inspired things happening in your body that is likely to bring on cancer. And not only give you something for it, but interdict it before it happens. Actually help with gene modification to provide your body with a defense it doesn't have to that cancer before it arrives. That's the golden ring we reach for. And that can happen in our country. We do 70% of the world's research on this kind of stuff. We do 80% of the new biologics in the world. This country, I will predict to you, will soon be about the business of providing medicines that don't just treat, don't just focus on the damage done by all the chronic disease, but actually predicts their occurrence, interdicts them in advance, gets to them early in the progress of that disease, and in your individual case provides you with the medicine that makes a difference in your life. Now, somehow we have to meld what we do in CER to that progress. We can't take it the other way and just give everybody the average medicine. That average, on an average, serves you. We have to move with the science. We have to make sure that in our country we respect this incredible and dramatic advance of science and bend our policy to make it work and to make it save money and to save lives at the same time. Can it happen? Will it be transformational? It'll be amazing. It'll truly be amazing. I learned in my cancer progress that I could have avoided my cancer. I didn't know it. I didn't know the steps that led to my cancer. I know that now. But one day we'll all know that process. We'll know it intimately. We'll be developing techniques and technologies and nutritional series and nutritional understandings and medical technologies that are going to give us a chance never to go through what I went through. You see, I got a problem in my head right now. I didn't think I'd see any grandchildren 5 years ago. I didn't think I'd get a chance to walk my daughter down the aisle. I was pronounced dead. No chance to live. And by the grace of God and His great miracle of medicine, I saw 2 little grandsons born. And I walked my daughter down the aisle. More importantly, she had a father walking down the aisle. My grandkids have a grandfather who loves them and nurtures them. But I got a nagging thing now. I know that somewhere in my genome, I inherited from my mother, a 3-time cancer survivor, the propensity to cancer. And I know I've passed it on to the little grandkids. And it bothers the hell out of me. And I'm not going to rest, and none of us should rest in this room, until we can help ensure that the grandchildren, the sons and daughters and grandkids we create, don't have to experience what I went through. That's transformation. It's coming. Get ready for it.
Thank you. Okay. That's actually a great lead-in to about cancer and about transformation to hear from Dr. John Seffrin, who is the president and CEO for the last 17 years of the American Cancer Society and the Cancer Action Network. And he has actually been a leader on cancer prevention, tobacco control, and will share his big idea about what we can do about cancer today and what he knows and what he's learned from his research. So thank you.
Thank you, Peter. Good afternoon. Well, my big idea is simply creating a world with a lot less cancer and a lot more healthy birthdays is not only now a medical, scientific, and public health possibility, Julie, but it is now an economic and moral imperative. The American Cancer Society is the largest voluntary health organization in the world and one of the oldest. And it was about the time our organization was founded in 1913 that the late great American poet Robert Frost's mother, with metastatic breast cancer, came home to die. A terrible death. And shortly afterwards, he wrote a 4-line quatrain poem entitled A Question, which said, "A voice said, 'Look me in the stars, and tell me truly, men and women of earth, if all the soul and body scars were not too much to pay for birth.'" I've studied Robert Frost for 40 years, It's the only poem I ever read of his that I didn't like the first time I read it. He was interviewed later, and he said, no, it's not a final judgment about life. It's about a feeling you have when it's hopeless. And his mother's cancer was hopeless, and any diagnosis of cancer then, death sentence, only to be preceded by a protracted period of pain and suffering. Whew. Fast forward, when I got involved in cancer work, still, most people who got it died, but not all. About a third lived. And today, most people who get cancer, like Billy, survive. And many thrive. Look at the energy he just put into his remarks. What more needs to be said? Everything I've said so far pretty much is a qualitative statement, because many people resonate to a qualitative. Tell me something I can understand. Let me give you a couple of numbers to put with that. Cancer mortality rates in the United States of America, age standardized, have gone down every year for 15 successive years, year over year. All of my life, heretofore, they were going up and up and up. And we've proven that those rates going down is an admixture of prevention and improved therapy. Roll it up, 650,000 Americans will celebrate a birthday this year who wouldn't have had we not been making that progress. Or to put it in a slightly different way, Billy, to personalize it, we're saving 273 more lives per day, every day. Now, Tony Fauci yesterday made several very important comments, but I think he was the one that used the phrase proof of concept. I think of this as proof of concept. When you get involved in something where most people die, and now most people are living and we're running out of the woods for the first time, and you hear what Billy just said, why are we saving 500 more lives a day? Why aren't we having 1 million more lives being saved? That is a real possibility. The American Cancer Society set 2015 goals, which was to reduce cancer mortality by 50% by the year 2015, back in the early 1990s. And I report to my board of directors and trustees every year, and we report to the nation, along with CDC and the National Cancer Institute, how we're doing. And we're proud that we're making progress. But I've got some really smart trustees, and they say, John, the line's going the right way, down, but are we going to make our goal? And I said, well, no. We're projecting out that we're going to get a little over halfway there. What do you suppose they said to me? Shall we change the goal? No. They said, Mr. CEO, John, come back to us and tell us what we've got to do to make it. Well, the good news is I'm surrounded by some terrific professionals, 2 of whom are in this room today, and some crackerjack epidemiologists and scientists. And in 2 years, we came back to the board and said, here's what we've got to do to make our 2015 goals, and we believe here's what we have to do to materially solve the public health problem we know of as cancer. 1, we've got to redouble our research effort. Basically, in my career, scientific inquiry and biomedical research, public health research, has gone from a good bet to a sure bet. It doesn't mean every experiment works. But we know it's a building block phenomenon that if we stoke the engines of research, we will get a return on that investment. What kind of a return? A life-saving return. And the reason I believe we'll be able to do the first one is because we've been too timid, almost tremulous in reporting the value of research to the American public and especially to policymakers. Mary Woolley heads up Research America, and Honorable John Porter know. You go into any congressional district, people say, we want research, we want more answers to our health problems, and we're willing to pay for it. So we've got to redouble research and balance that portfolio so that we really can maximize the health benefit to people. Second, we have to promote prevention into public policy and make it standard practice everywhere. 2/3 of all human cancer is preventable. 2/3. In America, 1.4 million new cases per year, 557,000 deaths. Do the math. Here we are in a nation where 90+% of our neonates are born healthy, and most, not all, most are genetically programmed to stay healthy for a normal human lifespan. Why don't we leverage our assets? You can't say that in sub-Saharan Africa, but you can say it here. So we've got to promote prevention into public policy. Thirdly, and this is a key point, we've got to provide access to quality health care to everyone in America. Now, what's interesting about the three things we need to do, and I doubt that anyone in the room is hearing any one of those things that they haven't heard before, but each is essential. Each is necessary, and none is sufficient. We've got to do all three of them. But if we do, the ROI is that we can begin to talk about bringing cancer under control early in this new century. You could not intellectually talk about that just a few years, or certainly a few decades ago. We established, I actually was a volunteer chairman of the board of the American Cancer Society when we established a national cancer database with the American College of Surgeons. Very controversial. Just put more money into basic research. We've got SEER data and so forth, but we didn't have reliable data on stage of diagnosis and whether you had insurance coverage or not, and outcome. And it's the only cancer database in America that has all three of those in it. And so we started mining those data only to find out that not only, as you would expect, if you don't have access to health care, if you don't have health insurance, you're much more likely to present with an advanced cancer, and advanced cancer is, of course, much more lethal. What we found is even if you present with an early cancer, such as an early breast cancer stage 1 or an early colon cancer stage 1, you're more apt to die if you don't have health insurance than if you have health insurance and you have a stage 2 colon cancer. So the system is broken in very fundamental ways, and until and unless we can provide quality access to health care for everyone, we'll continue to see excess morbidity and excess mortality. I believe it's a moral imperative and an economic imperative. Published economics literature, as I said to Senator Daschle this morning, shows that a 20% reduction in cancer mortality, which is in the bank, is a $10 trillion value to the American people. When I first read the numbers, I thought, I'm not an economist. I said, can that be true? And Don can respond to that. But according to Topel and Murphy, the distinguished professors of economics in the University of Chicago, had published those data, and I went to an independent economist. He says, yes, John, I quote them all the time. But it's also a moral imperative, because how many people didn't say along the way, if only we could do more for this poor suffering person, if only we could have avoided this event. Well, that's where we are. So we have an opportunity unlike ever before. We've been trying to change the healthcare system for the better part of a half century, but we're in a different place today. And we're in a different place because we now know what's going to happen if we intervene. We've proven that when people have access to good health care, you change the outcomes. But we also know what's going to happen in an aging population if you don't go there. So demographics is an interesting science because, as an example, they remind me that we know for sure that in 30 years we're going to be 30 years older. But are we going to be 30 years older in a disabled population or a healthy population? Well, let me conclude by saying my mother always say, Johnny, where there's a will, there's a way. I would submit today we have the way. We need to generate the will. Thank you very much.
Well, I can attest we're certainly 10 minutes from listening to that big idea. We've actually learned so much. Now I want to shift gears one more time and go down to the patient level and actually how people actually engage the healthcare system itself. We've heard a lot about macro policy and about some real experiences in terms of personalized medicine and in terms of what we can do with cancer. And now we're going to bring Grace Bender up, who's the founder of Infinicity and who has one of their main products is My Medical Manager. And if you open up your packets, we all receive them, so there's no excuse not for using it. So Grace is going to share with us her big idea about how consumers engage the interaction between the patient and the medical care system and how that can be transformational as well. So welcome.
Thank you. First, I want to say I was born in Washington, D.C., and I'm 2 years older. I'm 6, so I've been around politics a long time, and I've seen a lot of changes. And this new transformation of healthcare, I hope it works because there's a lot of things that are wrong in the system. So I hope my little presentation will help you become your own healthcare advocate. And that also means helping your family and friends. And I'm going to give you some statistics. I'm not trying to alarm you, but I am trying to arm you and have better doctor's appointments and so forth. Okay, let's see. Reasons to be your own healthcare advocate. Doctors are really only spending between 7 and 12 minutes on your ailment, performing the examination, diagnosing and prescribing your medications. A great deal more time is frequently spent dictating and covering for insurance policies and get reimbursement and to cover so they don't have a malpractice. Medical errors by both physicians and hospitals are still very prevalent throughout the country. I'm sure all of you remember the Dennis Quaid with the twins in California, where heparin was passed through 3 professionals. It was the adult dosage and given to twins, and they nearly died. This is not intentional, but it is happening, and it's still happening a lot. There are still staggering numbers of patients being misdiagnosed each year in all fields of medicine. The biggest problem is that numerous prescriptions and over-the-counter medications are prescribed by various physicians and are not being reviewed on a regular basis. People have no idea what the ingredients and combinations are creating. Medications can help you. They can save your life, but trust me, if they're taken incorrectly, they can do more harm and they can even kill you. In spite of all the discussion about technology to improve medical errors, only 1.5% of U.S. hospitals have a comprehensive electronic record system. And I want to tell you, this came from the New England Journal of Medicine, April '09. That was based on 63% of the hospitals responding back. Now, that's a very sophisticated, comprehensive electronic system. And I want to digress a little bit here because what we all assume, technology is wonderful, but we may be a good 5 to 10 years away from being able to go into a hospital and having them be able to contact your pharmacy and knowing what medications you're on. So in the interim, I'm suggesting that all of you know every single medication you're on, write it down, and keep it in your wallet or keep it with you in case of an emergency or have it at home. And a lot of people are telling me, well, I have it on my computer. Frequently, people have passwords to get into their computer, and then some of these medical websites have passwords. In the time of an emergency, you don't have time to do that. I think, and probably the most important reason to be your own advocate is this fact. Adverse events related to medication are the 4th leading cause of death in the United States in patients 65 and over. That's inexcusable. It's just ridiculous. And we're the only ones who are putting that medication in our system. Almost 90% of the pharmacies are wired to receive prescriptions electronically, but only 20% of doctors are using these e-scripts. So the bottom line is you must take charge of your own health care. Keep copies of your records. Do your own research. Know your body. Ask questions. But most important of all, you must have that accurate, up-to-date list of all prescriptions and over-the-counter medications. Have it reviewed regularly. Take it with you. I've given everybody my Med Manager spiral notebook. I hope you'll use it, even if you just fill out the medication chart and have it reviewed by your doctors. But remember, the healthcare reform is here, and we're going to get something. But the spending, $1.6 trillion over the next 10 years, may not cure what's ailing the medical system. And I think we all have a responsibility to participate in helping it be a better system. Help our doctors diagnose us better. Help our pharmacists be able to tell us you're taking the wrong medications and to do different things. Now, I'm going to go through this quickly. 1/3 of Americans are on 5 or more prescriptions weekly. Spending in the United States in 2006 was $216.7 billion. That was 5 times as much that was spent in 1990. This next slide, the reason I want to show you this is to show you how much damage or how much we're spending to take care of misuse of medications. In 2001, U.S. citizens spent $144 billion on prescription drugs. That's not the over-the-counter prescription. However, more than $177 billion was spent on additional health care expenses, hospitalizations, and problems resulting from the improper use of drugs. So therefore, for every dollar we spent, $1.23 had to be spent to take care of these, taking the medications incorrectly. Another study showed that in the year 2012, which we're getting closer to, we're going to be up to $450 billion. So just do the math. Now this $450 billion does include increased number of people using the medications, but think what we're going to be spending and the clogging up of the emergency rooms with this kind of thing. But just when you're taking a pill, make sure you read the instructions that are the little yellow stickers on the bottles. Make sure all the other printed material you read. My story, how I became my mother's and my own healthcare advocate. I designed this product basically for my mother. She was on 16 prescriptions, 6 over-the-counter, and having more and more symptoms. As a result, I came up with this system. I did a spreadsheet, and this, I want you, whether you use this or you're going to make your own list, it is critical to have the exact name of the medication, not just I'm on a diuretic, I'm on a heart pill, whatever. List it. And the strength, you could be on something that's 25 milligrams, but you may be taking it 3 times a day. That could be 75 milligrams. Your doctors need to know this. The emergency rooms need to know this. I always said if I could save one life, I'd feel happy. Well, Elise Benton, photographed here, had a heart attack. She went to a hospital in Media, Pennsylvania. She was on 26 different medications and was allergic to most. The emergency room doctor said that if she had not had that, she would have died. They would have given her the wrong things. Now, you can either use my system or you can go to Baldo's Aunt Carmen's system. But let me go back to just a couple of things. My mother was able to go from the 16 prescriptions down to 12 and then eventually down to 9. Now, the pharmaceutical companies might not like to hear that, except she was taking them on a regular basis because it wasn't so complicated and she wasn't creating more problems with the interactions of things. My brother was diagnosed with having a bruised lung, and the bruised lung and some strained muscles. He was in Pasadena, Maryland. Went to a hospital there, had emergency room, couldn't breathe. They x-rayed him. They said, well, the good news is you're not having a heart attack and you don't have lung cancer. I said, come up to Washington. I'm going to find out what's your problem. He was in stage 4 of multiple myeloma. A blood test would have told him that. To make a long story short, we found that out in 1 day of testing. And so the importance of different locations and what you can do. I'm happy to say he had a stem cell transplant at Johns Hopkins, and he is in remission at the moment. Fast forward, he goes to the same doctors this February, keeps complaining about a cold. He goes into the hospital with pneumonia. He's not getting any better. I called and intervened with Hopkins. I called the oncologist and I said, you know, you told me he was your star patient. I said, well, you're about to lose him. They transported him. He had to have emergency surgery. It looked like he had lung cancer or something. It was just incredible. they said he had a 50% chance of living. He didn't die from the multiple myeloma, but because of pneumonia. My own case I want to tell you about is I had a lung scare in February of last year, and I know I'm going a couple minutes over. I hope you're okay. And I keep all my records. I have a notebook. I save all my blood results. When I have a scan or x-ray, I get the little CDs with them, and I keep them in my book, and I go to every doctor with them. And when I had that scare about my lung, because I had the CD that showed I had nothing the previous year, he asked me, have you had a clear mammogram and colonoscopy? I was able to go and check the dates, and my manager told him I had. But I said, I want to take an MRI breast scan, because I've read if you have a family history of it and you have very dense, large breasts, that's the best way. I had that test done. To everyone's shock, I had 3 spots in my left breast. They then had me do a mammogram that showed 0. They then had me do an ultrasound. The clinician checked me out, and she said, you know, maybe they wanted me to do the right breast, not the left. Well, that, you know, was very reassuring. Then she finally went and got the radiologist, who found, after 20 minutes, only 2 spots. I, as a result of that, had a biopsy done by MRI, and it was determined all 3 were malignant. I had a bilateral mastectomy February 28th of 2008. As a result of that decision, the doctor said, you may not have found out you had breast cancer for another 2 years or 3 years, and it would have been a very different outcome. I also did not need radiation or chemo. So all I'm doing is encouraging all of you to just be your own advocate. Take notes. Ask your doctor. Go on the internet. And I will tell you, www.mayoclinic.com is one of the best resources I've ever found. You can put in a symptom, and it'll give you some of the diseases it could be. You can put in the disease, and it'll explain everything. I'm sorry I ran over my time, but I hope you'll use the book. If you don't, give it to somebody who could. Thank you so much.
2 things stand out there for me, I think, and it's why healthcare is unlike anything else that we study in terms of public policy, is that it's human. It's our lives. It's how we live. It's how we die. And second is that for all of our conversation about big public policy decisions and transformation, we can't forget the little things, like day-to-day about taking the medicines and understanding medication errors. We're going to close with a big finish. I can promise, with Miss Rhonda Monroe, who is living with heart disease and is the national spokeswoman for Women Heart. She's also a poet, so if we can, maybe we could ask her for a little poetry at the end. But I welcome, she's going to talk about who is responsible for health and where does that responsibility lie. So that's her big idea.
How interesting that everyone here stood behind the podium and every man took center stage. Very much like in life, right? Good afternoon. I really am honored to be here among all of you today, but especially my esteemed panel members. I really am excited about joining you today to explore the next frontier of American healthcare. As Peter told you, my name is Rhonda Monroe, and for the next few moments, I'll share with you my perspective, a patient's perspective of what must take place to truly reform healthcare in America. But before we look ahead, I ask that you journey with me, and this is for you, as I detail my experiences poetically through our healthcare system over the past 5 years. Question: do you know what it's like to be in pain, only to be turned away feeling ashamed after you've been told your mind is to blame? Well, I do. And not just me, but others too. My story is unfortunate but true, and though it's heartbreaking, the next victim could be you. In May 2004, I should have been on top of the world. After having 2 sons, I delivered a precious baby girl. And while all things seemed to point to a happy end, that's where the nightmare was really about to begin. 4 days postpartum, as I was nursing my child, I felt a pain in my left arm that began somewhat mild. The next day, that pain came creeping back, the first telltale sign of a heart attack. I remember thinking, me? A heart attack? That's whack. In fact, I'm the picture of health. Or so I convinced myself. Well, it wasn't whack. And the tiredness that my obstetrician laughed at was really due to a blood supply lack. Aha. The first hint at medical slack. But that's nothing, because soon you'll be taken aback by the things that I've suffered, the joy that I've lost, the hardship I've endured, the incredibly high cost. As I stated, the next day, that pain came back again, and then it was accompanied by numbness and tingling, chest pain and shortness of breath. I knew I was in trouble, but couldn't imagine to what depth. I couldn't imagine to what depth. I broke out sweating and started vomiting along with that pain. And right about then, that elephant came and plopped right down in the center of my chest. I couldn't get him off, though I tried my best. Boy, was my faith being put to the test. We called 911, and to the ER I went, only to be sent back home. After testing and observation, diagnosis unknown. But take these pain pills with you. Your muscles are just sore from the birth you went through. True, but that's not the problem. Didn't you hear me say I have pain in my heart? I've sought medical attention. Now do your part. The pain wouldn't relent, so I went back a second time. Again, I was told that everything was fine. By this time, the ER doctor seemed quite annoyed, as if his perfect diagnosis record was about to be destroyed. He said he saw no reason to keep me, could be pain from a slipped disc, and when I tried to ask a question, he ignored me like I didn't exist. The next day, I went to the doctor, who sent me back to the hospital for tests. I'm sure by now you see a pattern, so you can guess the rest. Home again with no answers, but the nightmare really begins as I writhe all night in pain, praying and repenting for my sins. As death pressed in around me, I prayed, Lord, what do I do? He said to pray for wisdom, for the doctors to diagnose you. Of course, why didn't I think of that? Now I had the master's plan, so I dragged back into the ER with my trust in God and not in man. I was greeted with an, oh, you again? Weren't you here the other day? Please kindly sign yourself in and stay out of our way. Stay out of the way? Here the other day, much to my dismay, I had to wait 2 hours before being seen. A lady with allergies was put in front of me. Now that was just plain mean. I thought to myself, these people really don't care about my health. I finally made it to triage where my vitals were taken. Could I be mistaken for a patient they actually needed to see? Then back to emergency room 1B, a room designated critical cardiology. After an EKG and an x-ray, everyone started running my way. Hysteria. Pure hysteria. Notify her next of kin. Where's the person who brought her in? Call an ambulance. Bring the forms. This heart pattern is out of the norm. Bump, 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 bump. My heart was pounding, and I was still in pain. But somehow, their attitudes had suddenly changed. In walks the cardiologist from earlier in the week. He opened his mouth and began to speak. Young lady, I'm glad you were persistent. Turns out you were right. You are having a heart attack, and now we'll try to save your life. My life? My life? And what's this about going under the knife? What happened next seems surreal. 5 dissected arteries, a quadruple bypass, unreal. What's the deal? How do I feel? I feel grateful to still be alive, that the Lord showed me favor that I might survive. I could have died, almost did, yet God forbid. I'm grateful I'm still here to raise my kids. How long will we let things go wrong, singing the same tired song about what someone's body will and will not do? How can you say unless it's happened to you? Every case can't be the exception, nor can each one be the rule. We've got to be proactive and seek new intervention tools. It's time. Past time, high time, overtime, overdue time, listening time, prime time, do or die time. It's my time to speak up. And you're in luck, because I am not afraid. I will raise my voice. There is no other choice. I must. It is only just for us patients to have an advocate as well. And boy, have I got a story to tell. If need be, I will yell to break down past traditions and help others get well. Don't expect me to sell myself short. I am a member of the true royal court. I will speak, I will write, I will make the most of this hand I've been dealt. This is my story. It's worth telling, and it is truly heartfelt. Ladies and gentlemen, what I shared with you was the beginning of a 7-day journey during which I sought but failed to receive proper medical treatment. I was seen at the hospital 6 out of those 7 days, where I was dismissed first as a hysterical new mother, though it was my 3rd child. My chest pain was subsequently misdiagnosed as a slip disc, and my clearly abnormal EKG, which indicated that I was having an acute myocardial infarction, was dismissed as a fluke because I did not look like a typical heart patient. On day 7 of this ordeal, I waited 2 hours in the ER waiting room before a nurse finally took me to the cardiac care area. It was then that I was rushed into emergency bypass surgery. Amazingly, I faced similar obstacles to adequate health care in subsequent months as I developed arrhythmias, went into congestive heart failure, and was eventually placed on the long-term care ward awaiting death because my bypass graft shut down after only 7 months. Since May 2004, I've died 3 times. I've had 3 heart attacks, 5 of my coronary arteries dissected, which means they tore. I've had a quadruple bypass, a double bypass, part of my heart cut off, 15 laser holes drilled in my heart, a pericardial window cut in the sac around my heart, and several other procedures. Yes, I am the bionic woman. By God's grace, I stand before you today, like Billy Tozen, a living miracle. But had I not been persistent and advocated for myself, I'm certain the outcome would have not been favorable. During that week in May 2004, as I fought to have someone listen to me, I vowed to take full ownership of my health, and I have. I've become an educated partner of my healthcare team, well-versed in the language and procedures of cardiac care. So what's my big idea to reform this healthcare crisis we're facing? Well, I certainly agree that healthcare policy on every level needs to be revamped, from legislative policy to institutional and hospital policy, and most definitely business policy to include insurance and pharmaceutical companies. I contend, like most, that access, quality, and cost must be addressed. Yet, I'm convinced that we'll fall short of true reformation until individuals begin to take charge of their own health. It seems that in our post-9/11 culture, many, if not most, Americans have become skeptical, even cynical, of any information presented to them, unless it comes from a doctor. When it comes to our health, we blindly accept whatever we're told, perhaps because it takes the ownership and accountability from us and lets it rest in the hands of the experts. Newsflash: there is no greater expert on you than you. I'm living proof of that. Statistics, family history, my personal health history deemed it improbable, if not impossible, for me to have a heart attack 5 days after birth at 36 years old. Today, my battle scars prove otherwise. I listened to my body, advocated for myself, and then educated myself. In fact, I continue to learn all that I can about cardiovascular disease. But how will individual responsibility and education lead to reform? I believe it will produce educated consumers who can articulate their ills and intelligently partner with professionals to plan an effective course of treatment. Such a process will reduce the added demand on systemic resources caused by our current lax approach to personal health. It's not rocket science. In fact, it's the lesson that my mother taught me as I began kindergarten. Rhonda, she said, you can't control anyone else, but you can control your actions. And today, I encourage you that as we begin to take measures to bring about reform in our respective areas of expertise, that you consider the patient's perspective and that you hold them accountable for their own health. My personal accountability and resolve saved my life. And because I'm still here, and I'm grateful to be here, I raise my voice on behalf of the millions of women living with heart disease. I'm a patient, but I'm also a Women Heart champion. I partner with Women Heart, the National Coalition for Women and Heart Disease, because it offers resources that empower me to be in charge of my health and to educate other women so that they too can be in charge of their health. That, ladies and gentlemen, is my idea of a great foundation for true reform. So what's the big idea? It begins with you. Thank you. And Grace is right. Although I need to make a new one, I brought this up here. Yes, I absolutely be in charge of your health. These are my medicines and my medical history, although I need to make a new one. I can use my med manager now. I don't have to have this one. Thank you.
Thank you. In closing, I'd like to just thank the speakers. I think we've all been very much provoked to aspire and go further. But I want to point out, one of the things that became very clear in listening to Rhonda and all the speakers is not just that they came here today and gave you very encouraging words and very provocative thoughts. I think the thing that we all should be most impressed about is they all walk the talk. Whether it's Senator Daschle or Billy Tozen or Dr. Nabel or Grace Bender, they are living, and Dr. Seffrin and Rhonda, they are living their big ideas and making them happen. And I think that's a challenge to all of us. It is not just to have the big idea, it's to actually live the idea and see it actually come true. So for that, I applaud our panelists and all of you. Thank you. So I think that concludes the session, and there we go. On to the next.